Thank you very much, Doron, for introducing. As he said, I'm a hand, wrist, shoulder and elbow surgeon. I practice out of 4 of our locations, and we've just opened a new consulting area in Bella Vista. Details of that will come up on our website soon. It's only just opened. My topic for today is Dupuytren's disease. This is a suggestion that came up after our feedback session from last year. So just to let you know, we do read your feedback sessions, feedback reports, and this is something that was requested. And particularly, I'm going to ask the question, can this be treated without an operation? Well, first of all, what is Dupuytren's disease? I think most of us have seen patients with this. We know it's a fibrotic change in the fascia of the palm of the hand. In the early stages, it might just be a little dimple or a little lump. And as it progresses, it's a chronic condition. It goes on for many years. Eventually, it leads to a Dupuytren's contracture, as you can see in this photo. So there's the cord that's been caused by our Dupuytren's disease. The line there showing the actual cord itself. And what happens over time is the finger starts to flex and the patient's unable to extend. Now, we don't know the cause of this. We know there's some sort of genetic background to it. We know that it's due to the fibroblasts forming a contractile ability. They form myofibroblasts, and then they contract down over time. Well, we don't yet have a way to stop that happening. Now, because it's a problem with fascia, it can happen in other parts of the body as well. And it's given different names, and it has a similar sort of characteristic. Something, in our hand case, gets bent. Other parts of the body get bent too. Now, it's really important, I think, that if you have someone with a disease, which is going to be chronic, the patient needs to be educated as to what is going to come with time. Make sure you have the knowledge to do that, or if not, get an expert on board. So a bit of advertising. In our practice, I'm the expert for this, supposedly. We do have someone for the feet. There's 2 of them. Some of us are experts at other bits of the body as well. Can we prevent it happening? Well, I've already said it's a bit hard because we don't understand the underlying abnormality from a biological perspective, but perhaps we might try a splint. Seems a good idea when you've got a bit of the body that's bending over. Unfortunately, it doesn't really work because the forces caused by these changes are far too great for a splint to hold. What does work is radiotherapy, interestingly, but we don't like doing that for obvious reasons. Skin problems, other problems with cells in the areas, possibly causing cancers, so it's not really something we do on a clinical level. Maybe you could change your parents? Look, there are biological type things being investigated, but nothing as yet on the market, all in experimental stages. Well, once it does happen, how can we treat it? Well, traditionally, patients usually end up with some sort of open operation. Gash on the hand and something done underneath. But there are some smaller procedures that can be done as well. When we're talking about open operations, that's known as a fasciectomy. Okay, so a fascia in the hand, ectomy being removal of. So we remove the parts of the hand which is causing the problem. Perhaps, though, we want a smaller procedure, fasciotomy, otomy being cut. So we'll just cut it instead of taking it out. Or we'll dissolve it with an injection called a collagenase. Collagen is the predominant tissue in this disease, collagen type 3. And of course, the A's part at the end of it means remove, dissolve. So we're dissolving the problem. When we're talking about fasciectomies up the top of this slide, there's 2 ways of doing that. We can either remove everything in the hand. It's quite a big procedure. Or we can do a limited operation, which means we just take out the part which is a problem, the diseased tissue. The issue, though, when making a decision like this is when do we do this? When do we proceed to either an open operation or something a little bit smaller? because this is a disease that might progress over many years. It might stall for a year or 2 or 5 and then progress a bit more. Generally speaking, if a patient can't put their hand flat on a tabletop, that's the time to consider doing something, whichever procedure you decide, because that means that they have a flexion deformity of approximately 30 degrees. And we know that when we get beyond, say, 40 degrees in the PIP joint, it often becomes an irreversible problem in terms of achieving full extension. We can treat the disease, but the joint undergoes secondary changes. Let's have a look at fasciectomy. Here's an example of a limited fasciectomy. There's the disease along there. We'll take the dots away again so you can see that. But it's a pretty big operation. Once we've taken it out, the patient has a relatively big scar. They may need some skin flaps in order to cover the defect left when we stretch the skin out. But it heals up reasonably well, and they can get a very good outcome from this. But there are risks. It's a big procedure. There are digital nerves nearby. If you look at our photo, there's our disease. Those arrows point to the nerves about 5 millimeters away there in green. And in other areas of the fingers, the nerves actually are wrapped around by the disease. So you take the disease out, you have to pry the nerves out from within the actual disease itself. In severe disease, we don't get full extension of the hand, and it can recur down the line. The recurrence rate for this is about 15%. If we look at this in a sort of table form, we can see that it's a very good operation. It has a broad indication, for lots of patients can have it. It's very effective, generally speaking, and it has a reasonably low recurrence rate. 15% over a number of years, 10, 20-year period is not bad. But high cost, big operation, moderate morbidity, and a long recovery time. So that's where these other smaller procedures come in. In the office, so consulting rooms or small procedure room, we can put a needle into the actual cord itself, sweep the needle back and forth, and cut the cord. This procedure deals with the problem here of the high cost, long recovery time very well. But the recurrence rate now is about 70%, so it's a much higher recurrence rate. I think in this circumstance, where I find this procedure useful myself is if a patient who doesn't want a big procedure, or as a staging operation towards a larger, staging procedure towards a larger operation. So someone who comes in with a very bad contracture, we might do this as a first stage to get their hand from, say, here to here. That makes it technically easier at time of operation once we've managed to clean the skin, deal with any skin breakdown that might have occurred as a result of moisture from having a contracted finger. Once we've done that, we can then proceed to the actual operation, and technically that becomes easier because suddenly I, as a surgeon, can see, whereas a finger like this, it's very hard to operate in there. Perhaps something, though, in between might be able to deal with all of these problems adequately, and that's where this thing came into play. This has been on the Australian market only for about 3 years. Collagenase injection, drawn up in a vial, injected into the Dupuytren's cord, left to sit for about 24 to 72 hours, and then, once the cord is dissolved, a simple manipulation in order to straighten the finger. But as you can see here, there's quite a bit of bruising, bleeding. The patients can get skin tears, and often we don't get a complete correction again and need a second injection down the line. So it's okay. We've sort of dealt with some of these. It's a compromise between the two. There are still some problems. It's a relatively complex injection because you don't want to inject the tendon underneath or the nerve next to it. And it's, again, not as effective as a large surgical operation. Recurrence rate's about 40% or so. Putting it all together, it's not that simple, really. I think it comes on a one-to-one discussion with the patient. What's important to them? What do they want to do? Is it important they get back to work? Are they happy to take a higher risk of recurrence? Or do they want a one-off surgery where everything is dealt with, takes longer, but the outcomes are better? What do we do after these procedures? Well, it's a fairly straightforward thing. I don't think it's anything complicated here. Wound care, swelling control, start the moving, prevent an early recurrence or early contractures, prevent a late recurrence. And that's actually hard to do here because a late recurrence, we're talking a year or 2 years or 5 years down the line, is probably due to the disease being activated in adjacent tissue. So we can't do anything with that, but we can prevent early recurrence. We want to restore function by getting them moving. Whether or not to use a splint's a little bit controversial in this. Traditionally, a splint is used for about 3 months, but there is some evidence coming into play now that perhaps the splint may actually lead to problems in itself and an increase in something called a flare reaction. This is where the patient responds badly after the operation with pain and swelling, which occurs probably about 5% of patients, like excessive pain and swelling, and the splint may contribute to that as well. I do tend to use a splint still for a short period of time, especially after the large open operation, but after the smaller procedures, I don't think it's as important. Okay, so that's, I think, the summary of Dupuytren's disease. The bottom line here is make sure you've got some knowledge. It's difficult, it's complicated. Lock into a local expert or someone you can call on or send the patient to if there is any question that you have or the patient has. And we have experts in many fields here. Thank you very much.